So somebody that has had a neurological impairment, you know two pieces of information. You know that proprioceptive input does what?
Increase tone.
It normalizes tone. So if it's low, it will increase it. If it's high, it will decrease it. So you get to make a clinical decision. You get to choose if you want to transfer that person to the weak side in order to force weight bearing, or if you want to transfer that patient to the unaffected side in order to facilitate whatever comes next, right? In a more efficient manner. At the beginning of treatment, right after somebody has had a traumatic brain injury or a stroke or some spinal cord injury, you are going to go towards the stronger side because they will be more successful. As soon as you feel like they are cognitively processing or they've got that down, you want to start transferring to the affected side or more affected side in order for them to improve generalization and carry over in a functional environment, right? Okay, so if Stacy has had a traumatic brain injury, a stroke, if she's got multiple sclerosis, if she has Parkinson's, any of those diagnoses generally create a more affected side and a less affected side, right? Okay, so if this is the first time she's getting out of bed, what side do I want her to get up on?
Strong side.
The strong side. If this is the 18th time she's getting out of bed, what side do I want her to get up on? The weaker side. So, if I come in, I decide I'm going to get her up on the weaker side, where do I put the chair? Up by her head. Up by the head is the answer. That's always how you set up the environment. If you have two sides to figure out, then if you move the chair, this left side is her weaker chair, towards her head, when she stands up, she's going to have to transfer to the left. Okay? If I was going to have her get up on the right side, I would put the chair on the right side so that when she stands up, she transfers to the right side. So that is the secret to success. If you are in a place where the room does not work, that you have two options, then you have to have the patient sit up and move the head to the opposite side of the bed so that you can control what side they get up on. Or you can get up on the strong side, go into the therapy room and use a plinth and practice getting up on the more affected side. All right? Okay. So what do I need to think about before we do the transfer? Actually, this time I'm going to have her get up on this side because I want the camera to pick up what I do. So I'm going to set up my environment first. What do I do with the wheelchair legs? Swing them out.
Lock it.
Take them off. Get them out of the way. If all you do is swing them back,
You can swing forward.
they can swing forward. If they get knocked, they can create a tripping hazard. I totally take them off and I put them in a place where they are not going to be in my way. So sometimes in a patient's room that's under the bed so that they're handy for me when I'm ready to put them back on. Okay.
So are we doing the weaker side or the stronger side right now?
Well, we can call this the weaker side. I just adjusted so that the camera would be in the right place. What do I do with the casters?
They're straight, but they should be back. The larger side should be under the chair.
Right. So in folks who are high fall risk, and in your book from Rehab 1, it says to keep the casters forward because it increases the size of the base of support. Right? I've never had an issue with that. And what I have had an issue with is patients tripping over the caster wheels. So I don't use my hands, I use my foot. And because poo-poo shoes and floors and things like that, I don't need to have my hands in. And then I push those caster wheels back out of the way. Okay. And then I can either angle the chair if I like to. What else can I do to make this easier?
Take the side arms.
Take off the rest. Somebody taught you well. armrest comes off. Okay, working it.
One hand.
And then you use your finger.
I didn't.
How did you do that?
She's real strong.
I just go underneath it.
No, how did you do that?
How did I do this?
Yeah.
A ball bounced from the floor as I was turning. My hand was relaxed. It hit in just the right way that it dislocated my finger. And I'm not, okay, I should clarify. I'm not 100% sure it dislocated my finger. I'm beginning to think that what it did was bust a blood vessel. And the weird motion of my finger was actually the tendon getting stuck in the tendon sheath, which is called tenosynovitis. And so every time I flex a little bit, the tendon is swollen, so it gets popped through that sheath and hurts like a string of curse words and horrible things. And then I have to extend it and pull it, that knot back through.
Just from a stability ball?
A stability ball. I know. I know. I got the hedgehog with the neurological diagnosis. I can dislocate my finger or cause big problems with a stability ball. A lucky lady. Okay. So, if you want to go ahead and can you scoot that way just a little bit? Look at how independent she is with that. All right. Here's where you get to use the high-low and hospital beds to your advantage. And what I would recommend is if you need to do shoes and things like that, do that while your patient is supine. So you don't have to be without your hands once they're sitting up. So she, look at that, I already got her shoes on her.
Oh, that's not good. Question, with hospital beds, you can put the head up. Are we trying to do like full side of the body, normalized tone, or are we maybe putting the head of the bed up to help them get up easier?
All right, so the question was, can you utilize the head of the bed to facilitate getting out of bed or going from supine to sit? And if they have a Craft-O-Matic bed at home, then I'm okay with that. They can use their Craft-O-Matic bed and elevate the head of the bed. Most individuals don't, and so I don't usually do that unless that patient has significant orthostatic hypotension or is pretty near dependent, and I need to save my energy for the hoist into the chair. So I only utilize that as a method of blood pressure control or reducing how much effort that 2 or 3 people who have to do the transfer put into that transfer, right? Because it's just not as functional. You have any input on that? No. Stacy says no, she has no input on it. Because we're recording.
I'm the patient.
You're the patient.
TBI.
Oh, she has a TBI. Don't cuss. They all do, so don't cuss. All right. So now that I'm ready to roll, if I'm going to help her with bed mobility, I want to utilize good body mechanics, and I want this handy so I can elevate and lower the bed as necessary. And then I would like you to bend this leg. Can you bend that leg? Good. Now, in one fell swoop, I didn't introduce myself, but she knows me, it's okay. I want you to roll to your side. Okay. So I am here, but I did not help her. I had hands on, but what I'm doing is assessing as she rolls how much help she needs. And if I start with, all right, we're gonna roll, right, I'm gonna say she was dependent when she wasn't. So I need to see what she can do and be ready if she needs my help. All right, so now what I want you to do is push with this hand and that elbow as you shift your knees and feet off of the bed and sit up. There you go. Good. So I used a cue down on the pelvis to help her sit up. First thing I'm going to do is get her feet on the floor. Whoop. Where are you going? You got somewhere to be? Yeah. And then get the seat belt. Get the gate belt on. And then put that belt on without pinching any soft tissue, especially if it's female. I have frequently asked my female patients to lift soft tissue so that I can get the gate belt on safely. Gate belt. Speaking of, you want to zoom in on this? Can you?
Let's see.
So many of you, I'm going to show you again. I don't know if you could see when I was recording at home, but the gate belt, the teeth point towards the direction of the buccal portion, not the buccal portion, of the end portion. You put the end portion through the buccal on the teeth side from the inside to the outside. So if you see, what I mean is,
So I always remember because the back will go towards the.
yeah, the back has the seam in it where the belt
will
has
go
been
towards
sewn onto the
their
buckle.
body.
So from the back of the belt to the front of the belt. Snug it up. Too much? I'm a tight gate
You
belt
are a
person.
tight gate.
I am. All right, and then through the back side of the belt. Right. I do the little loop-de-loo. You don't have to because this bugs me, and I don't like it when it's hanging down because it's usually right in front, and that can be a little vulnerable. So then I make a little buckle so that it doesn't loosen as I go. All right, that's the gate belt. All right, so once my patient's ready, I'm going to get the chair closer now, right? Okay. And then what I want to do is prepare my patient for the transfer. So if we need weight bearing, if we need just orientation, make sure she's not dizzy. Are you having any dizziness, any pain? All right, what I want you to do is make sure both hands are flat on that bed. And I want you to kind of lean forward a little bit. Good. And lean back. So what am I doing here?
Getting ready.
I'm getting her ready, but I'm putting proprioceptive input through her knees, through her shoulders. She's in good shape. All right, here's what we're going to do. You don't know how to assist? Okay. If I wanted her to stand all the way up, I can have her stand all the way up. If I just want like a squat pivot, then we'll do a squat pivot. And I can have her reach all the way to the armrest to make that easier for me. So squat pivot, I tend to put my foot in between the knees. That way if I need to support a knee to keep it from buckling, I can. Can you reach across for that armrest? Good. And then what we're going to do is you can look out that window so your nose doesn't get smooshed on my shoulder. On 3, I want you to just lift yourself up and pull yourself into that chair. 1, you 2 count, I'm sorry. 2, 3. Yeah. Okay. All right. And then I will position her. All right. If she can stand up all the way, then I want her to stand up all the way. And then if she's standing up, so go ahead and do a stand at this point. So scoot forward. You want your armrest back down. It's safety first. Okay. So what I want you to do now is just go ahead and stand up. Yeah. Good. Okay. So now, once she's standing, I don't have to do the quick swoop into whatever chair or other surface. This could be the intervention, a sit to stand. And now I can start pre-gait activities, right? Okay. Good. So what we're going to do is back. Yeah. There you go. Whoop, I let you flop. Sorry about that. We'll work on that. Are there any transfer questions? Do you know how to make a transfer and intervention? Anybody ever heard of the functional outcome measure 5 times sit to stand?
Mm-hmm.
That's gross lower extremity strength. If you wanted to use something like 5 times sit to stand for somebody with a neurological diagnosis, you can do 5 times partial sit to stand and work on midline orientation with a mirror, right? And you would be beside the patient during the transfer and encourage them with a target on the mirror to lean forward, straight ahead, not leaning to one side. And then you can do the get weight equally on both legs, have a seat. Get weight equally on both legs, have a seat. Okay. Shift to getting weight equally on both legs, stand up. Now keep that nose at the target while you reverse that, lean forward. Now you got mini squats, right? And they have visual feedback to practice keeping equal weight through their lower extremities. Sometimes, oh, don't pause, don't stop. Sometimes I use PVC. And I've wrapped that sticky paper, the fly paper, dice them on it. And then the patient has a midline cue. If I need to, I can use an ACE wrap to keep their hands on the pole because I want both arms engaged in the process, right? And what they do is push that pole forward. So it's another way to keep midline. If the pole shifts, they're not in midline, are they? So the pole works to encourage midline orientation. If I ask them to push down on the pole, they can push down. That helps with proprioceptive input. That helps with a cue to move up. Okay? So you can take, yes, got a question.
When did you decide to use a walker when you're doing transfers?
So if it depends on the intent of the intervention. So if I'm working on transfers for home, I would start with a walker. If I'm working on something that I want to carry over to that walker, like midline orientation, weight bearing, bilaterally, it's more segmental. I'm not doing the full transfer. The walker is going to be both hands and sometimes one. And it's easier to cheat with a walker and lean towards one side to stand up than it is with this. Because this gives them more cueing and a center orientation. So if I'm trying to get midline orientation and equal weight bearing, the intent of the transfer isn't to go from point A to point B. The intent of the transfer is midline orientation and weight bearing equally through both legs, right? So this is an intervention as opposed to transfer training, right? Do you see the difference? Okay. If it is true transfer training, after I do this, then I will put the walker in front of them. Okay? So when I put the walker in front, can you, one somebody get me a walker? Perfect. Thank you. So who didn't set up the environment? How tall are you?
5'5".
No, it's going to be pretty close. Okay, 5'5". So, if I want her to be successful, then I need to shift the chair a little bit because I don't want her getting used to standing up cockeyed, right? And then I would choose, yep.
Would you have it super close to them, or are we wanting them to focus on pushing up from the chair and not reaching over the walker?
I, especially neuro-wise, I want them to push up with both hands. Because what hand do you think they're going to reach for the walker with?
Strong.
Strong hand.
Their They're not.
They're not?
No, they will put their weak hand up there because that's not the one they can push up with. Right? They're gonna take the path of least resistance. So I don't, in fact, as a rule, and because a lot of my patients have been neuro patients, I don't let them rest a hand on the walker. It's just not what I do. It's not my habit. I want both hands on the chair. Okay?
Pull it back towards them too, so it can uneven.
Right. Right. So I would do, and I tend to put this right in front of them for a couple of reasons. One is a lot of these folks are afraid of falling. And if I have this far away and I'm standing beside them, it feels like an infinite amount of space to fall into, and I don't want that. I want them to feel like they don't have much fall risk. I can give them a center point. That's where your nose needs to aim or your chin needs to aim. Okay? Can you scoot forward with you? All right, now both hands on the armrests. All right, and then I can be here, and if I have to, right, I can support, or I use ACE wraps. I've used things called air casts or air splints to support a low tone extremity, and we'll talk about that here in a second. Lean forward and push up. Both hands push, push, push. Once you've got your weight over your feet, then you can reach for that walker. Nice work. Okay? So that's how that would work. All right. You can stop